Okay, folks. So now that we've talked about some of the basics of depression, I want to focus on some of the workhorses in treatment of depression and anxiety. So these are things that work on serotonin and norepinephrine for depression. So just kind of looking at the big picture here, this you can think of as like a family tree. So on one side, on the left, we have the drugs that work on monoamines. On the right side, we've got drugs that work on amino acids such as glutamate and GABA. We'll talk about those in a different lecture, but I want to focus on the MAOIs, the tricyclics, the selective serotonin reuptake inhibitors, and more recently the SNRIs and the SSRI plus medications like vortioxetine. So you can see these medications kind of, they are iterative. They are hopefully improvements on a theme. But this gives you some idea of when they began, the MAOI starting in the 1950s, and some of the more common medications that you're familiar with for treatment of depression, like the SSRIs, really coming out in the 1980s and 1990s. So this sort of prototypical treatment for depression and anxiety is often the SSRI. This is selective serotonin reuptake inhibitors. And these are not directly activating serotonin receptors, but they are increasing the amount of serotonin in the synapse by inhibiting the transporter of that serotonin back up into the presynaptic terminal. So they are indirectly increasing the amount of serotonin that is available, and that activation of those postsynaptic serotonin receptors rather. Fluoxetine was the first, came out in 1987, and then we had a whole slew of SSRIs coming out in the late 80s and early 90s, and they really enabled the more widespread biological treatment of depression, because depression up to that point was largely treated through psychotherapy. There was some biological psychiatry, there was some use of tricyclic antidepressants, but there was a lot of hesitancy because of their lethality and overdose, and because they have a lot of side effects. All the SSRIs are sort of similarly effective. They have varying degrees of different side effects, but they share in common. They can cause sexual dysfunction. They can cause some GI distress, particularly at the beginning, insomnia, particularly at the beginning, and they take a few weeks to begin to work. This is just for your reference here, but really all these medications, there's a lot of interchangeability of SSRIs with regards to what treatments we're using them for. So what conditions we're using them to treat, rather. So now some of the companies like Pfizer, when they had sertraline on patent, Zoloft, they did a lot of studies looking at varying different conditions. So you see OCD, panic disorder, major depression, et cetera there. It doesn't mean that, say, something like escitalopram couldn't treat those things, but it may not have an FDA indication. So technically off-label, but very conventionally used. And these are the usual doses that you see here. The serotonin norepinephrine reuptake inhibitors, or SNRIs, or the serotonin agonist reuptake inhibitors, these are also useful for depression and anxiety. So these are also medications you're probably familiar with, like venlafaxine, which is known as Effexor, desvenlafaxine, which is the first metabolite of venlafaxine, sold as a new drug, even though it's really not a new drug. It's sort of old wine in new bottles. That's sold as Prestique. And now venlafaxine is only acting on norepinephrine and serotonin at higher doses. So typically doses of above 75 or 150 milligrams is when we begin to see inhibition of the norepinephrine transporter in addition to the serotonin transporter. At those lower doses, venlafaxine is basically just an SSRI. Duloxetine, on the other hand, inhibits serotonin and norepinephrine at all doses. And then some of these atypical antidepressants, such as mirtazapine, those not only cause release of serotonin and norepinephrine through mechanisms which I'll get into, but also block serotonin 2A and 2C receptors. Trazodone First comes out as an antidepressant around 1981. Not particularly successful because of its sedating properties, but that became leveraged as an off-label sleeping medication in up till the current day. We still use a lot of trazodone in lower doses than we would for depression. So antidepressant doses of trazodone are sort of in the 150 to 300 milligram range, but we use trazodone for sleep in the 25 to 100 milligram range. I've kind of talked about this before, so I won't belabor it, but we're inhibiting that reuptake pump, which takes those neurotransmitters, those monoamine neurotransmitters, brings them back up into the presynaptic terminal to be used again. So since that's inhibited, going more slowly now, those neurotransmitters more likely to get over to the other side and activate the postsynaptic receptors, which then initiates this downstream process. Now, with all these antidepressants to choose from, where should you start? I'm going to be prescriptive here. You can make your own decisions when you're in practice, but I'll tell you what I do, which is often starting with escitalopram, which is Lexapro. The reason why I do this, it's been around for a while, so I feel like it's pretty a well-known drug. I find it as effective as all the other medications. It's fairly reasonable on side effects. It has all the usual SSRI side effects, but it doesn't hit, say, muscarinic acetylcholine receptors, so it doesn't have anticholinergic side effects. Generally doesn't cause a lot of weight gain, plays well with other drugs. So I like it for that reason. It has all the same problems that all of the SSRIs do, which doesn't work for a while. You get side effects before you get benefit. You can get sexual dysfunction. They can cause problems in patients that turn out to be bipolar that you don't know that are bipolar yet. And this issue around suicidal, uh, initiating suicidal ideation, particularly in young people, which I'll get into detail in a moment. Escitalopram is typically started at 5 to 10 milligrams. If you have a patient who's particularly sensitive, you could go lower than that, but typically 5 milligrams for a few days and then going up to 10 milligrams is a reasonable strategy. Some people will just go ahead and start at 10 milligrams, and I think that's not unreasonable. It does take a few weeks to work, like you're familiar with all of the antidepressants, and typically you're going to wind up somewhere between 10 and 30 milligrams as an effective dose. If you do see some response, but the person isn't getting better yet, isn't fully better yet, think about pushing the dose. It's reasonable to go up on this dose until you find something that works for the patient, unless they're having no response. If they're having no response, then you should probably think about changing the medication to something else. Now let's take a look at why you get these different side effects from these medications. So we can think of this as kind of grouping into central nervous system side effects, GI side effects, sexual dysfunction, and weight gain. Let's break them down. These are the things that will really tend to make patients stop taking medications. If you cause people to gain weight, lose their sexual function, or feel sedated or cognitively impaired during the day, they're likely going to quit their meds, and you can understand why. I think most people would not feel real excited about tolerating these kind of side effects. And so these are things we generally want to avoid, or at the very least, warn patients about them and get their informed consent before they start on the medication. Now, because we're inhibiting serotonin across the entire body, we have some side effects that are due to that increased serotonin. And so one of the things that can cause restlessness or akathisia is this increased serotonin at the basal ganglia. So it's activating serotonin 2A receptors, and this can cause this sort of restless, uncomfortable feeling that sometimes people will get when you start them on an SSRI. In the old days of fluoxetine first coming out on the market, we didn't really know what dose to start people on. And so people were often getting started on very high doses, like 60 or 80 milligrams, and they were kind of jumping out of their skin. And so this is why we generally start these medications at lower doses and then work our way up. It allows for the central nervous system to kind of accommodate this extra serotonin. And so this sort of stimulation effects go away after a few days of exposure to the medication. Increasing serotonin in other areas of the brain, such as the hypothalamus, where the chemoreceptor trigger zone is, that can induce nausea and sometimes even vomiting in some people. So the serotonin 3 receptor is what's being activated there by that extra serotonin and can account for some of the nausea side effects that we can get with serotonergic agents. Because there are a lot of serotonin receptors in the gut, particularly serotonin 3 and 4 receptors, we can see changes in motility, so increased motility leading to diarrhea, sometimes slowed motility leading to constipation. I would say that probably diarrhea is more common, and sometimes people can get cramping with that phenomenon. Now, what about antidepressants causing suicidal ideation? This certainly got a lot of press about 20 years ago when this black box warning came out. And I think it's important to unpack this because this is a common misconception which can actually harm patients because they'll think that it's not safe to get treatment. And the risk of treatment emergent suicidal ideation is fairly low, and it's fairly limited to people who are young. So by young, I mean under the age of 24, 25. And let's go ahead and break this down. It's also important to note that, of course, depression itself puts people at higher risk for suicidal ideation. So it's difficult sometimes to disentangle what is caused by the drug and what is caused by the disease. And it's also important to sort of break down how we define suicidality. So obviously, suicidal acts have to begin with a thought, and we call that suicidal ideation. Now, many people with depression have suicidal ideation that never leads to any action or intent, and it's important to define that. So just because somebody is having suicidal thoughts does not necessarily mean that they're going to carry out a suicidal attempt or die by suicide, but we do need to sort of stratify the risk. And this is a science. Suicidology is a an important thing to understand as a clinician, but this is just a very basic concept here that we start with a suicidal thought. If that advances into a preparatory act, say obtaining means or doing research about how to take one's life, and then that leading up to an attempt and then eventually death. Obviously, suicidal ideation is the first step in this process, and it's often defined as the, appropriately so, as a conservative marker of potential suicidality. But it doesn't necessarily mean that somebody with suicidal ideation has made a suicide attempt. And this black box warning came about by looking at an analysis of all the almost 5,000 people that had been in antidepressant trials over the course of 24 different studies of 9 antidepressants. So we're working with a pool of about 4,500 people. And what they found was that when you compared the people that were exposed to the antidepressant compared to the people that were on placebo, that about 2% of people who had the placebo reported new suicidal ideation. And only about 4% of people who had gotten the antidepressant reported new suicidal ideation. The good thing is nobody actually took their own lives. But the concern here was that going from 2% to 4%, while the absolute number is relatively small, that's still a doubling of risk. Or you can be optimistic about that and say, well, 96% of people did not have treatment emergent suicidal ideation. The FDA tends to lean more conservative, so they issued the black box warning. Now, does that mean you shouldn't treat patients, even young patients, with antidepressant medications? No. In fact, that's what happened in the year following the black box warning. There was this drop in use of antidepressants with young people, and that led to, well, or was associated with, I don't know if it led to it, but there was a correlation with an uptick of suicides the next year in that same population group. So, did we save people from a side effect only to let them suffer the natural course of their disease? I don't know. But regardless, what we need to do is we need to tell people, look, when you start this medication, you're probably not going to feel much of anything with regard to your mood for the first few weeks. You're probably going to get some physical side effects like diarrhea or headache that should go away after a week or so. But if you notice that there's a significant worsening of how you feel in terms of your mental health. And by that, I mean your depression getting worse, you're not able to sleep, you can't turn your mind off because you're so anxious or your thoughts are racing, or if you have suicidal thoughts that you've never had before, I need to know about it right away. And I want you to stop the medication and get in touch with me. And you create ways for patients to be able to contact you, whether that's through secure messaging or calling your office. You need to have some way for people to let you know this is happening so that you can deal with it. But I think if you do that, you monitor, you document, you'll be okay. Now, let's change topics and talk about sex. So, a lot of times, there's, I think, some well-intended but probably prudish uh, pharmaceutical company came up with this euphemistic term of sexual side effects, and I've never really known what it meant. Is that a side effect that you want to have more sex, or is there something wrong with your sexual function? It means the latter, unfortunately, and we should be really more clear about what we mean by this. And so what we're talking about is antidepressant induced sexual dysfunction. And we can break this down into really sort of three or four different areas of function. So we can think about decreased interest in sex, so just a decreased libido. We can think about difficulty with arousal. So that means in people with penises, difficulty with erection, people with vulvas, difficulty with engorgement and lubrication, and then difficulty with orgasm or difficulty with ejaculation. There can be something called anhedonic orgasm, which means that there's an orgasm, but it doesn't feel that great, doesn't give that much pleasure. So I would say probably of all these side effects, the most common thing is delayed or inability to orgasm as a result of these serotonin medications. It happens to about 40 to 50% of people who take them. Some people, it's an ongoing side effect. For other people, it is something that will happen for a few weeks and then kind of drop off as their body gets used to the medication. Why does this happen? It has to do with how serotonergic medications inhibit the flow of blood to the genitals. So this whole sort of process involves nitric oxide synthase, which breaks down L-arginine into nitric oxide, which then causes smooth muscle relaxation and blood flow. Now, SSRIs, serotonergic medications, inhibit this enzyme. And so by inhibiting that enzyme, they don't create the nitric oxide, you don't get the smooth muscle relaxation, you don't get physical arousal. Now, why do these medications inhibit orgasm? This has to do with the balance between serotonin and norepinephrine. And so obviously in order to have a orgasm, you've got to have mental sexual excitement, there's got to be something that's interesting to you, and there has to be physical stimulation. Those two things generally need to go together. Norepinephrine is its job is to facilitate orgasm. Serotonin's job is to inhibit orgasm. So there's this kind of dynamic balance that exists between these two influences. Now, if we introduce an SSRI into the mix, we kind of put our thumb on the side of the serotonin, and that inhibits the potential for orgasm. Now, you might be thinking already, well, wait a second, is this why we add bupropion, which is a noradrenergic medication, to SSRIs to restore the ability to orgasm? And you would be absolutely right to consider that because we're now sort of rebalancing this a little bit, putting a little more norepinephrine influence into the mix, decreasing this overdominance of serotonin, and hopefully allowing people to have orgasms again, which is a good thing. Okay. Why do people gain weight on antidepressant medications? It's complicated. There's a lot of different inputs, if you will. Serotonin 2C activation is definitely associated with increased appetite. We see this with mirtazapine. It may be the kind of foods that people are drawn to. So maybe going more towards a fat and carbohydrate preference. Maybe being more thirsty because of dry mouth can lead to more fluid intake. If that fluid is caloric, we see an uptake in increased calories there. The blocking of histamine receptors, blocking of acetylcholine muscarinic receptors can also contribute to weight gain. So there's lots of different things that go into that. We may disrupt the basal metabolic rate, so the amount of calories somebody needs each day to kind of keep organs functioning could go down. And if that's the case, then if the amount of food continues to be the same, you're going to have excess calories that'll get stored as fat. So there's a lot happening here. And many of these medications can have antihistaminic and anticholinergic side effects. So we see that as sort of sedation, fatigue, dry mouth. In older people who have less sort of cholinergic reserve, we can see a confusion that can set in, or even a full-on delirium if we have sufficient anticholinergic blockade. So we want to be careful with that, especially with our older patients or patients with sort of already sort of incipient cognitive issues. So let's say your escitalopram fails and you still want to go with an SSRI. I think sertraline is a reasonable next step. I think fluoxetine is a reasonable next step. Both are cheap and readily available. Fluoxetine, I typically start at 20 milligrams. Some people like to start at 10. I don't see a lot of value in that unless somebody's super sensitive to the medication, but usually 20 milligrams and go up in 20 milligram increments. Sertraline, I will usually start at 50 and then go to 100 milligrams. That's usually the sort of lowest that you're going to see some response. Some people get better on 75, even 50 milligrams, but I'd say in my experience, most people need at least 100, and I can go up as high as 200 or even 300 milligrams. I generally don't use paroxetine. I think it's kind of an icky drug, and I might consider going to duloxetine at this point, which is an SNRI. I wouldn't use citalopram. And why is that? If escitalopram fails, why wouldn't I use citalopram? Well, remember that citalopram is a racemic mixture of R-citalopram and S-citalopram. And it's really the S-citalopram, the left side of the molecule, that's doing all the work. And so adding citalopram or switching to citalopram would really be redundant. So that's that reminder about enantiomers that we've discussed before. Now, one place where citalopram does have some challenges is in this question of QT prolongation. So remembering your cardiac electrophysiology, the QT interval is that period right before depolarization of the ventricles, leading up to the period of repolarization. So from the Q to the T wave. So that interval typically in most people is somewhere under about 430, 450 milliseconds. When we get longer than that, we consider that QT prolongation. And some of these medications can prolong that even further. If it gets too long, we can get into arrhythmias like Torsades de Pons. So we want to be careful not to prolong an already prolonged QT interval. And so this is where really the right enantiomer of citalopram was problematic. So our citalopram, if we compare these two columns here, so remembering that the dose of escitalopram is half of that of citalopram because we're only focusing on that left side of the molecule, so you only need 50%. So 20 milligrams of citalopram is equivalent to 10 milligrams of escitalopram. So let's go down this a little bit further. Let's pause for my dog. All right, pausing for my dog. Thank you for your patience there. So let's take a look at higher doses of citalopram. So like 60 milligrams, we see this QT prolongation by 18 and a half milliseconds, whereas the equivalent dose of escitalopram only increased by 10 milliseconds. This was enough to get the FDA concerned, especially about doses. They drew the line at 40 milligrams. So they said 12 and a half milliseconds of QT prolongation on average is probably okay, but 18 milliseconds is not. And that's where the FDA black box warning came out around decreasing citalopram doses or keeping citalopram doses below 40 milligrams for the general population. And in older people who are more prone to QT prolongation anyways, having even lower of a threshold at 20 milligrams. I would stay away from citalopram with people that are already prone to having QT prolongations. So people that have had hypokalemia or recent MI, I would just stay away from citalopram. With anxiety disorders, SSRIs are also very helpful, and they are sometimes used at higher doses, particularly with OCD. We will often use SSRIs at doses above the labeled amount. So I mentioned with sertraline, we might use a 300 milligram dose of sertraline for OCD. Very common. It's fine to do that. You want to document that you're doing that. Talk with the patient that it's an off-label use, but often we need these higher doses for OCD. Patients with anxiety sometimes do have this sensitivity to the experience of the inside of their body, sort of interoceptive sensitivity. And so for those folks, I will often start at a lower dose and go up very slowly. So be much more gentle with this so that you don't get people sort of uncomfortable and then not wanting to stop the medication because they feel that's exacerbating their anxiety. The other place where you can start would be bupropion, which is Wellbutrin, of course. This is basically like a weak methylphenidate because it's inhibiting both norepinephrine and dopamine transporters. And this has been around for a long time, came out in 1985, so it actually predates fluoxetine. And it is not working on serotonin, which is nice. So it doesn't cause sexual dysfunction, which is nice. And it generally doesn't cause weight gain, which is nice. It doesn't cause sedation, which is nice. If anything, it can be a little bit stimulating, which is probably on account of that sort of methylphenidate-like effects. So you definitely dose this in the morning. I'm fond of the extended release format of this drug because it's once a day. Take it once in the morning and forget it. Now, if you forget and you realize it's 4 o'clock and you haven't taken it, you should probably skip it that day because it has that stimulating effect, could keep you awake at night. There is one, this, I know I talked about going higher with some of the SSRIs. With this, with bupropion, you don't want to go above 450 milligrams total dose per day. And the reason for that is because there was it was identified that people were at higher risk for having seizures with high doses of bupropion. So we don't use bupropion in people that have had seizures, and we don't go above 450 milligrams. There are a couple of other forms besides the extended release. There's immediate release, which is actually a 3 times a day dosing. I can't remember the last time I used that. Maybe I've used it with somebody that had a gastric bypass that couldn't absorb medication easily. There's a sustained release, which is BID dosing, but like I said, most of the time I use the extended release. Um, Little trivia, atomoxetine, also known as Strattera, was rolled out by Eli Lilly as a kind of bupropion killer. It was going to be the competitor to bupropion. Didn't actually work out very well as an antidepressant in clinical trials. And so Lilly went back to the drawing board and said, they cynically, some people would say they kind of concocted the concept of adult ADHD because at that time ADHD was seen as a disorder of children, which children grew out of, and adults didn't have it. But they introduced this idea of adult ADHD, which is certainly an idea that has taken a significant foothold. And that atomoxetine was a treatment for that. And so, just a little bit of interesting kind of trivia in the history of these medications. Bupropion, very easy to use. Like I said, take it first thing in the morning. I like that it doesn't cause weight gain, and you don't want to use it with people with seizures or are prone to having seizures. And so, two groups of people that might be more prone to having seizures are people that are drinking a lot of alcohol and then stopping because that sort of withdrawal syndrome predisposes people to having seizures, and also people with bulimia nervosa because frequent nausea, not vomiting rather, can disrupt electrolytes. Disrupted electrolytes can lead to a lower seizure threshold. So we want to be careful with that. The other value for bupropion is that it's useful for helping people stop smoking. So this actually has Zyban is the name for the same drug in a different package that is used for the treatment of smoking cessation. May work on some of those nicotinic receptors, may have, because it has the ability to increase dopamine, might reduce some of the sort of craving that people get when they're trying to quit smoking. But regardless, this can be a helpful thing to add, especially to something like varenicline or to nicotine replacement strategies, such as gum or patches, in order to help people stop smoking. It's a great 2-for-1 if somebody has depression and they also want to stop smoking. So in the next step, we're going to talk about what should you do if these things fail using something called STAR-D, which is an older federally funded real life depression study to examine what to do next if your first line treatments fail. So stay tuned. Thanks.